And then the other thing that I just forgot to realize is that to have the, the images here so that I can share them with you. Boom, boom, boom. What's the name? Bear with me. Okay. Okay. Copy files. Okay, here we go. Fine. Okay. So this is a case that came, I think, a week ago or something like that, to the clinic, and it was the history is that it's a vomiting, middle-aged vomiting cat, and then it was referred for an ultrasound, and I guess it was, I think it was a Friday, and I was overwhelmed with ultrasounds one after the other. So usually people that were with me there in the clinic know that my first question when someone come and ask for an ultrasound, in particular for a vomiting animal, I always, it's kind of a reflex that I have. It's like, do you have radiographs? Because radiographs can, they're not like something not to pay attention to or something to say, well, it's first line diagnostic modality, and then we just move on immediately to ultrasound. Sometimes there's a lot of information that we can get, and it's, I suppose, cheaper, faster, it can be shared. So there are many advantages, and I have a feeling that sometimes we underrate, sometimes we don't pay too much attention, or yeah. So yeah, that's why I like this case. That's the a little bit of a framework about the case. So it was a real case, came from in the clinic, vomiting cat, I think for 2 days, referred for an ultrasound. I was overwhelmed with other ultrasounds, and I said, do you have radiographs? I don't think they had radiographs at the time. And then so I said, while I'm ultrasounding these other patients, go and take radiographs. And this is what we've seen. So after that introduction, now we go in our routine, which is findings. We try to make up a story, and then we make a decision about if we are happy with a diagnosis or if we want to do something else, what we would recommend. So I'm all ears now. And so because I'm assuming that this case may be boring or I don't know, boring, but some people know about it. Then I have another very interesting case also related to things that we are seeing in the clinic lately. So I'm trying to come back and give some clinical relevance to our discussions, not to always talk about things in the air. Okay, anyway, what do you think? Are we technically okay? You can hear me, you can see the images, you got the link. Okay,
yeah,
cool.
Good.
Yeah, I can hear you, Anna. I can see everything.
So I assume there is nothing jumping or overwhelmingly abnormal. Otherwise, you usually are vocal. You immediately say, well, I dislike this or the other.
That's not a valid assumption, Mariano.
Okay, cool.
Yes. There's very good abdominal detail, which
Okay, yeah.
is good. Looks like very good technique. I can see the colon. The radiograph is abnormal. The radiographs are abnormal.
Okay, good.
So I think I can see most of the colon going up and then around here. And I think on the VD, I think this might be colon as well, like the ascending colon potentially. So I'm not sure. I'm just trying to work out what this organ is and whether it is stomach or a mass. and also where these pockets are located. That's why I haven't said anything yet, because I'm still trying to think about it.
No, well, so I think this is exactly the exercise that we want to do. So, and I guess it goes into a personal decision to decide to stay quiet until you have something that you can articulate in a nice way, make sense, without hesitation. Or I think that some people prefer to do that, and that's okay. Another thing that I really like, and sometimes I take myself, is to say, you need to warn whoever is listening to you, but to say, now I'm gonna think aloud. Makes sense? Now I'm gonna, like you did. I said, like, it looks a good detail that strikes me as a very easy thing, or that caught my attention. Then this is the column. I don't like this structure. So you are not saying I'm certain what it is. I think it's abnormal, but I'm not sure what it is. I'm between these two options. Makes sense? So that thinking aloud, I think it's an excellent exercise. And also when we are learning and interacting, I think that gives someone else the opportunity to say, I think I saw the same thing and this is my consideration. Makes sense? So then you can start moving on with that question. So if you don't know how to answer, but you can put it out that somehow you don't like something, someone else can come and say, well, I agree with you and I think it's this. What do you think? So again, philosophically, I like that attitude of thinking aloud. And it does. Sometimes you just go one direction and then you decide to come back and say, no, that was the wrong direction to go. And then I need to come back and I need to start again. But I know some other people that struggle with this a lot, and they stay quiet until they do all that thinking quietly, until only when they are able to provide a clear explanation of what they see, only then they would come up with a talking. And so I'm okay with either way, but I'm very much okay with the thinking aloud process. I think it's very useful.
Okay.
Anyway, so I agree with some of your things, and I guess I wonder if there are comments around about what you mentioned.
Well, one of the things that interests me is that we've got what's probably small intestine there, and the same there. But on this view, it appears to be confined to the right side. And it seems to be distinct from the colon, which you can see there. And initially, I was wondering whether we mightn't have had sort of carcinoma in situ throughout the omentum, but I decided against that because, to me, that what I've outlined in red seems to be more of a mass effect. There's something on this other side here that's pushing the small intestines across and confining them just to that right side.
Mm-hmm. Well, I insist, when I say cool or doesn't mean that I agree. I acknowledge the comment. But I'm letting all the comments, everything come out, and then I'm wishing for you to start taking each other's comments and seeing if you agree or disagree. So until now, as a summary, we have a comment about something abnormal in the cranial abdomen that I think we are all happy that is abnormal. We are uncertain what it is. And then we pointed at the colon in the two projections. And then the next point is that the small bowel seems to be displaced. So there is somehow a mass effect, and it's basically located in the caudal abdomen and left. Sorry, right, in the right caudal abdomen. So that's a summary of what you've said. Yeah, let's keep on bringing stuff. And then also take each other comments and question them, agree with them, disagree with them, whatever.
I think the thing that jumps out to me is that it's because it's a cat, it's got a really huge stomach for a cat. And you've got, particularly on the left lateral, you've got a gas sitting up against the pylorus. And then just on the other side of the pylorus in the sort of proximal duodenum, there's a mottled gas and sort of a little bit of soft tissue opacity, but just quite an unusual opacity in that sort of proximal duodenum that I'm worried is causing a obstruction and causing all that fluid and gas to build up in the stomach. I think the DV is slightly rotated, and I think maybe that's making the intestines look, maybe that's causing them to look more on one side, but I think perhaps that's slightly because it's a rotated view.
Can you show us, using your super technological knowledge about how to label images and everything, like what you meant about the stomach and
So I think that's the big stomach there. And then this is the weird looking thing that's sort of in that sort of area.
Cool.
And that thing.
So that now you are somehow you're moving forward from, there was in the beginning the description of this being an abnormal structure. Now you are moving on and saying, well, I agree it's abnormal, but not only is abnormal, but I think it's stomach. And I think it's enlarged. And I think it's enlarged because there may be an obstruction. And even moving forward, you say, well, there may be something abnormal here. If that is something in the duodenum, then I can put all of those findings together.
Because I think you can see it's quite nice on that left lateral because you can sort of see the pylorus sort of. Can't draw. Hang on.
That interests me.
Quite good.
The bone structure here. There's something abnormal going on there, I think. It seems to be irregular compared to the other side. And it's harder to identify it on the laterals, but you can. So there's some distortion, I think, of L7 and the sacrum.
Okay.
Is that radiopaque, like more radiodense material in the colon? Do you think the descending colon?
No, we are coming back to here. I'll suggest we hold on there for a minute, and then I want to come back to the stomach and ask for further. Let's say I am a difficult clinician, and I'm famous for not trusting or willing to have very strong arguments, for you to convince me that. So Helen or anyone, any additional argument to support that is the stomach?
I'm
I like
concerned
your
that
comments.
I can't think of any other organ that could be that distended. But I'm wondering if this is.
I can play a game and say, why is that not a splenic mass?
Because it looks fluid filled and there's gas in there. So because it's
okay, good. So that's the argument that I was after. So, and that's the reason. Again, we go back to the two projections of how helpful they are, and it's working perfectly in this case. So anatomically, this has to be the right side of the stomach, and it connects with the duodenum. So it should, if there is fluid and gas in the stomach, then and you position the animal in a left lateral projection, gas should go to the upper side, and it's going to be the right side. So that gas is coming here and then into the duodenum. Perfect. Probably not so much in the duodenum because there is the sphincter there. So, but in the pylorus, it makes perfect sense. And if we come back to the other projection, now this is the pylorus, and there are kind of these wavy contour that I think are peristaltic waves. And I think it makes sense in this case. So then now this is all fully fluid filled. And then the gas is now here, where is the fundus. So an additional, so it looked abnormal, is in the position of the stomach, is gas and fluid filled. And not only that, is behaving as an anatomical structure that has a component on the left and a component on the right, and then the fluid and gas is moving accordingly. So super strong evidence. Makes sense? So I'm just trying to make sure that we pull all of the evidence that we can accumulate, and then because then there may be another case in the future where you need to go and search for every evidence. I think probably is again an obvious thing we go through. Sometimes things are probably I go too much into detail into all the features, but yeah. So I agree with that comment. Anything else, or anything that you want to keep on getting and agreeing or disagreeing with the rest of your?
Is the duodenum normally in this area? Is that, I don't normally see it. Is that its typical location on a lateral?
Yeah.
Okay.
Yeah. So remember, and then probably that's a little bit of a disagreement, you know, I wouldn't call even a disagreement, but a clarification. So the stomach is a complex structure. So when Helen pointed to this being, I think she did here, pointed to this. I agree with all of these. The part that I disagree is that I would expect the stomach to go the other side of the stomach, the left side of the stomach, to go up, and then all of that. So the stomach in the lateral projection has a left-sided component, a right-sided, and the body. So it's not only, it doesn't stop here. So and you can see that here. So now we're in a right lateral projection. The left is up. There is gas in the left. So the stomach goes up to there, and sometimes it goes even more. And I wonder if it's going more, but because of fluid and gas, the gas is sitting on top. So actually, the stomach goes all the way up to here. And then this is the body, and then this is the right part. It's a small detail, but it's just to clarify where it sits anatomically. And I think the more we look at images, the more certain we are about where things should be, and then we rely on very small changes. So that's why I'm stressing that. And then we haven't talked about the stomach in this projection. So the stomach, so there is some. So this is going to be a VD projection. So this, even though we see some gas here and some gas here, I think the actual contour of the stomach is this one. So that's the border, and then there is a kind of an undulating pattern. I'm not sure where it comes here, because we have the kidney there, but then this is gas in the duodenum. And in the cut, the shape of the stomach has this characteristic appearance, kind of an U shape. Okay, question for you. Do you think this is the wall? So I'm telling you that this is the border of the stomach.
No,
No.
we're not falling for that one again.
Okay, good. So what is that?
You can't, because there's fluid and gas, so you can't actually make out the wall distinct from the fluid.
This is a beautiful example of what the book says. Stay away from judging the wall in a plane radiograph. And the reasoning behind that is that you can't separate wall from fluid. And this is a perfect example to make that point. So what you see here is the border between a soft tissue wall and peritoneum, which is fat. So that's line. So it's a single line. So you see only one edge of those two structures. Then the wall silhouettes or border faces with the fluid within the stomach. And then what we see here is the interface in between the fluid in the stomach and the gas in the stomach. So if I draw a line between this and this, then what we have is fluid and wall. we can't separate the wall from the fluid. So this is a very clear example of that, the justification for that statement about staying away from reading the wall. This is just a beautiful example. That's why I couldn't stay away from stressing that point. So coming back to the case, okay, anything else? Keep on moving on. Are we ready to make a call?
I've got
Are
a
we
couple of
certain?
questions more than, well, just
Okay.
statements, I guess. I mean, this cat doesn't look particularly fat, and yet if you look at its kidney, particularly on the left-hand side, it's really well demarcated. And as Bronwyn said earlier on, the whole abdomen is really well defined. So I don't think this is necessarily a pathologic thing, but I'm just curious, do you think that's just fat that's making it so well defined? Or is it just you've got great X-ray and a great X-ray machine? I don't know.
Yeah, good point. The answer to that question is going to be based on, it's going to be with a lot of certainty, because there are not too many options. Sometimes when there are too many options to an answer, then you need to say, well, I'm not sure. But the answer to that question, I'm going to do it with a lot of 100% certainty. And I'm going to say that there is fat outside. Why is that we see it so clearly? Maybe because of the technique, but there is no other answer. The only other answer to have those borders being so well defined is having gas outside. Because radiographically, if you are dealing with an animal, then we group things in these groups. Do you remember mineral, metal, mineral, soft tissue, fat, gas, and that's it. So now if the kidney is not mineralized, it's soft tissue, the liver is soft tissue, the small bowel is soft tissue, and so on, then if we can see the borders, because there is something with a different opacity outside, and then it can either be, there are only two options, fluid or gas. And gas will not be, so we had some cases of free gas in the abdomen. So unless there is a lot of gas, like post-op, which is going to be super contrasty, and then you will know about it. Otherwise, gas is going to be in pockets, and I don't see any pocket, and I just see darker. That's it. I take your comment about the technique. I think it's a very good technique. It's a very good system, and not only that, it's small in terms of thickness. Do you remember that technically one of the things that we deal with that results in poor contrast, meaning in a poor ability of the system to differentiate in between two pixels with different grays, is noise or is scatter radiation. So if you have like a similar, instead of having a cat that I don't know, maybe 10 centimeters thick, now you give me a Rottweiler, even this same system is not going to perform that well.
No.
Makes sense, because now there's going to be a lot of scatter radiation, and remember, scatter radiation is going to result in a loss of contrast. So it's going to be all the grays are going to come together. They're not going to be such a great difference. So I think the system is good. It's a cat. So those are two things in favor. Yeah. And the point again that I take is that it's an otherwise relatively thin animal. So that goes against expectation. So I'm not saying, oh, your comment is silly. I'm saying your comment is perfectly fine because you are following the right clue. You are saying the animal is thin, and then there seems to be a contradiction. If the animal is so thin, there is not so much sub-Q, not so much fat on the spine. So inguinal region is not that much. So now you're saying why there is so much detail. That's a perfectly fine thinking process. And then you get to the point where, well, the only way to answer that point is that if there is gas. There is no gas, and therefore it has to be technique. Makes sense? Yeah. So that would be the sequence.
Yeah, you have to work through.
Process. Yeah.
Okay, thanks.
Okay, questions? Anyone willing to move on to bring some certainty, to try to make up an explanation?
I'm just going to have a guess.
So I know
Or yes,
really.
that's another part of the exercise, to have this hypothesis testing. So you can, when you think, well, no, I want to guess, you guess and then you test your guess. Makes sense? So you say, well, if this is the case, can I explain everything that I found? And again, this is an exercise that not always needs to go straight forward. Sometimes you put a guess and then you say, well, it looked like a nice guess, but it's not actually. I need to take it back. And then you go with another one. So guesses are welcome.
I was just going to, I mean, I meant guess more to what the obstruction might be. I mean, I think we've ascertained that the obstruction is at the base of the stomach. So I was just going to say, I think it's probably hair would be the most common thing for a cat to have in the base of its stomach, but I'm not sure if that's what you're asking.
No, I'm asking about a guess. So do you have an answer to the big question? This cat was referred because it's vomiting. We've taken some radiographs. Those were our findings. Do we know why the cat is vomiting? And then how far can you go in your guess or in your assessment? So I take that from your answer that you think he's obstructed.
Yeah, there's obstruction, because we can't say it's foreign body, and there is dilation. Well, there is excess gas in the duodenum, so I don't think it's at the pyloric outflow. I think it could be also involving the duodenum. Maybe something tethered in the pyloric outflow potentially.
Good. How certain are you? What are you gonna do next? Are you gonna be sharpening the knives, or are you gonna be still asking me about an ultrasound?
You could scope.
Well, it would be good to know if it's neoplastic, I guess, before you go in, and that ultrasound will give you a better differentiation of the fluid versus tissue in the upper bowel.
Okay, I like that answer. Not because I probably disagree that, I don't tell you why, about the comment about the ultrasound. I agree with the justification of the ultrasound. So the conversation should be something like this. There is an obstructive pattern. So there is an obstruction in the duodenum, pylorus dash duodenum. I think you're right. It's in the duodenum. The supportive evidence is that the stomach is very severely distended. The small bowel is very empty. So then there is something that looks abnormal where the duodenum sits. So that's the description. That's the argument to conclude that there is a mechanical obstruction. So if you want to, the reasoning to go on in an ultrasound is to prove that there is an obstruction, my answer is no. If your justification for an ultrasound is to talk to the owner and say, well, look, there's an obstruction, the indication is to go in, but we want to know more. I want to be able to give you a prognosis. Do you want to know more, for the prognosis? Is the knowledge about if this is a mural lesion or a luminal lesion, is this a foreign body or a tumor in the wall? Is this going to change your decision about going in or not? Then doing the extra step will make more sense. This is a reasonable justification. In this particular case, the history was that the cat was playing, I don't know if I mentioned that, I'm tricky sometimes with the history. The cat was playing with a foreign body. And I feel pretty confident that see that there is something there with square margins. I think Helen mentioned that. So this seems to be like gas within a tube, and it is more homogeneous. And then there's kind of an abrupt angle here, and then something more kind of square. And then the pattern here is not so homogeneous. Again, I would be perfectly fine for you to say, I think you are crazy, or I will never have the confidence to make that call. And I will completely understand that point. Yeah, and that comes with time, and sometimes we make errors because we are confident. So the association between the history of this cat playing with a foreign body and then disappearance, and then the distension of the stomach and the very empty small bowel. For me, it was enough to say, I'm almost certain there is a foreign body there. Everything fits. And then, so I give you the answer. They went endoscopically because I remember talking to a clinician saying, you know, I don't know if you're going to be able to get that far. I don't think it's in the pylorus. I think it's in the proximal duodenum, but I'll give it a go. And then she was very, very good. She managed to get there and grab that foreign body. The problem was that, and when she pulled from the foreign body, the wall was kind of folding upon itself. So it seems that the foreign body couldn't be slide back into the stomach. It was kind of trapped. So then they need to go in surgically and kind of milk it back into the stomach. I don't know if you realize here, it's beautiful how you can see the wall. So this is the serosal contour, and then you can see how it comes back. And then here is the same thing. So there is really something enlarged there, distending that bowel, and then as it goes more caudally, it comes back to normal. Yeah, so it's just a beautiful radiographic example of an unusual radiolucent foreign body. Most of the foreign bodies are soft tissue opaque and so very hard to see. Some of them are mineral opaque or mineral or metal opaque, and few of them are lucent. I think it was a piece of foam. So which means basically
It was the yoga mat.
Yoga mat. Yes,
yeah.
I promise I will come back to this comment about the being irregular. I think there we are dealing with a difficult anatomical structure, and I have 2 points to comment. One is this one. I think there is a little bit of obliquity. I think there is the colon there with the feces and gas, and all of that is producing that I would probably call it heterogeneous, like irregular appearance. I would really like to come back and see if I see something abnormal there. Yeah, about to give you credit, I remember struggling with the pelvis and the sacrum are difficult structures. And I remember situations where we were after aggressive lesion. So, for example, it would be a transitional cell, and we're looking for mets or a prostatic carcinoma or some aggressive neoplasia. And we were after trying to define if we believe that there was an aggressive lesion in the sacrum or the pelvis. And sometimes it's bloody hard radiographically. Then you CT them and you see the lesions there jumping at you and very, very clear. So it's a confusing structure and it's a difficult structure. So I see your point, and I recognize that that's a difficult structure. And then sometimes we dismiss things because they don't fit in our explanation. And sometimes we go back and we realize that we were wrong. So I think in this particular case, because I don't see any other abnormality in the lateral projections and there is feces and gas in the colon, I think that's the case. And then the other point that I want to make is that your call, which is completely right, and is that there is not a single bowel loop in the left side of the abdomen. So why? And probably the only thing that I have to comment are two or three things. I think it's not only displaced to the right, but it's caudally displaced by the stomach. So that's one point. Why is it to the left? Helen's comment that is a little bit oblique. We like to blame obliquity for many things, so I take that one. Is minimally oblique. And the third one, which I think is the answer, is that cats are weird, and anatomically we know that cats do this. So this is not going to be your last cat where you see the bowel being kind of, I don't want to use the word clamped together because we reserve that word for our linear foreign body, but kind of bunching. Not bunching is also not good because we reserve that for our foreign body, but like located, if you want, in the right abdomen is the distribution of the fat, and this is described, is a known thing in cats. The thing that doesn't fit in this case is that is usually expected in very fat cats. So if you go in the book is going to say, well, the small bowel is useful to judge mass effects from different structures and all of that. And then it's going to give you an exception to the rule, and it's going to say that works perfectly fine, with the exception of fat cats where the small bowel may be in the right abdomen. So that is a known thing. Usually that assessment, I need to double check, but I'm pretty sure I'm right, is as in association with having a fat cat. This is an exception to the rule in that sense. But it's, yeah, so yeah, that's the point. If you want to go further and then don't like that explanation, then I think you need to go back to the principles. Is that small bowel enlarged? Is the content abnormal? Makes sense? So all the features, so size, shape, opacity, location. The location is a feature that we found that is abnormal. So then I will go, if you don't like that explanation, I will go systematically through the other findings and then decide, well, is that a variation of normal, or is there enough evidence for me to be concerned about it? And probably, I mean, a situation like this, like as I was mentioning before, the hypothesis testing exercise, I love reports. And I remember encouraging residents, or I encourage myself when I'm in a situation where I don't know. So if you're in a situation like this where you don't know, I think it's beautiful. And someone reading that, I think is going to be very thankful. If you say, I don't know, but these are my considerations. And you can even say, this is my consideration, this is my possible explanation, but I'm not sure because of this problem. And you outline your lack of knowledge. But you not only say, I don't know, you explain why you don't know. What are the arguments that are making you unable to be conclusive about something? That I think is a beautiful thing to do. So it's not to hide and say, no, I don't know, and I shouldn't say that. It's to openly say, I don't know, but then to be able to articulate why is that you don't know. Make sense? So what's the thing that doesn't fit? So in this case, obviously, I completely agree. The small bowel is also right. The consideration mentioned about, is there a mass displacing things, is a beautiful consideration. I don't see anything looking like a mass. So then that would be a nice discussion in the report to say, the small bowel is all to the right, but the size is okay, the opacity is okay. There is no mass displacing it. So, in theory, it could be a mass displacing it, but I don't see the mass. So, makes sense? So you are saying this is a hypothesis, it doesn't work. But these are the considerations that I have. And then someone reading that can completely understand where you're coming from. And maybe then you need to go, well, it's an anatomical variation, something that unusual in this particular patient. Now, this is a philosophical point. Coming back, this is not an unusual point. This particular point is not an unusual point in cats. The small bowel can be on the right, and it's an anatomical thing in cats. Okay.
So it's the concept that it just kind of proves that you're thinking about what you know isn't true, if that makes sense. So you can prove that you've thought about everything and you've gone, well, I don't understand why this is happening. I can rule out that this isn't happening, if that makes sense. So that you can show that you've thought your thought process. Exactly.
Okay. So that I remember, and maybe people disagreeing with me. I remember that for me was an everyday comment training a resident is, don't hide. If you see something that you don't like, but the mental tendency is if there's something bothering you, but if you don't know how to explain it, you just shut up. Because it's stressful. So that is the usual thing. I always thought about, and one day I'll do it, to think about, so now there are devices where we can track what you are seeing in the image. And then, so basically I can show you a set of images. I can put you, there are glasses, or not always glasses. There's a device that you can put next to a monitor. That's basically checking where, and with a precision, a very fine precision. So this is a very interesting research to do. So then I can see where you are looking at. And there are already many publications about this. And they basically discovered that some of the errors, or many of the errors, are not because you haven't seen something. It's because you've seen it too much. So there are areas that are really, really hot, meaning that they call your attention a lot. Your eyes were really trapped there, but you never mentioned them. And I think that happens because you don't know how to explain what
That's
is happening.
crazy technology that it can track.
Yeah. Well, but it's not even a very new technology. Now it's a well-known technology. And then based on that, there is also the technology where you look at something, and then before you close the exam, it's gonna tell you, you've been looking too much at this area. Do you want to rethink your report? Make sense? So it's gonna capture your pattern of how you looked at the image. And then it's gonna, before you close, it's gonna tell you, you look too much here, you look too much there. Do you want to reconsider? Because we know that errors are sometimes because of things that we overlook. But there are many errors, and if I'm not wrong, are the most common errors, or the most common errors, the ones that are more frequent, are because you've seen something call your attention too much. It's not that you haven't seen it, you've seen it too much, but you came up with the wrong explanation. You either ignore and it wasn't to be ignored, or you gave the wrong explanation. So that happens. And for me, I think I'm extrapolating my experience to everyone, but I think it's a relatively common thing. We tend to ignore some things that we don't know how to explain. So, and I think that's probably not good. I think you need to train to do the opposite, to say, well, I don't know about that. And then force yourself to put considerations. And I particularly love reports where someone is very honest and say, look, this is unusual. This usually doesn't show up like this. This is, the shape is abnormal, the location is abnormal, whatever. But I can't explain it. And I have these two possible explanations, but they are not perfect. They make sense. Like they are not. My explanation doesn't make complete sense. But you put it out. You explain it, and you not only explain why it's unusual, but why your solution doesn't work. And then you are leaving. Then you are saying you've seen it, and then you are also giving possible explanations. Someone can go move on from there. Ideally, you want to do that, and this is part of the examination in whatever boards or whatever in imaging, is to say, I have that problem. I don't know how to answer it. I suggest this to answer. Makes sense? So that's the next step, the famous next step. I don't know about this. So in this case, for example, if you are not certain about that, this would be a perfect case for in an exam situation to say, well, radiographically, in a plain radiograph, I cannot differentiate in between a mural lesion or a luminal lesion. But you need to have the knowledge to say, which is the modality that can answer that question and recommend that modality. So in this case, would be ultrasound or contrast. Make sense? So then you're saying, this is as much as I know. This is an obstruction. I think the obstruction is there. I don't know what it is, but if you want to know what it is, you should know this. So that's the path. Okay, again, I'm talking too much.
No,
but that's
helpful.
an interesting thing, that years ago it was really expensive to buy that thing, and now it's not that expensive. And you know where they use that? They use it for marketing. So they give people, like if you go to a supermarket, they give you those glasses in experiments. So then basically they can check, they can know where you look at things and what are the things that call your attention. So basically they can learn about our profile, about how things, what things call our attention and what are the things that we buy and we don't buy. So it comes, I think, the technology from there, but it has been used a lot in imaging also to track where you're looking at. And that is where we discovered that most of the errors are not because we don't see. It's not because we don't put our eyes in abnormal structures. It's because we don't know how to explain. There's some. It's more in the problem is more in the brain rather than in the eyes. Anyway, so I thought, usually I thought this would be too short. It wasn't too short. So then there is already the case. I already uploaded another case, which is a disease that we see very commonly. So we'll leave it for the next time.
Okay. Question before you go.
Yeah.
I'm
Yeah.
on mute. Just to confirm, I'm going to have to try and annotate it again. So if you're looking in the VD, you think this foreign body is probably there? Oh, you moved it.
You're
Yeah,
right.
tricking me. It's okay.
Yeah. I completely agree. I think it's there.
And then you probably said that, so this is still stomach because you, well, that's not the edge of the stomach. In fact, the edge of the stomach's probably there.
Yeah, I think it comes here, yes, and then even probably here. See this bumpy or undulating contour? I think it
We
comes
go
all the
down
way.
there. Yeah.
Yeah. So if I were, I think being able to identify that and be confident about that being an abnormal opacity and that being a foreign body, that's probably a next step. You need to have some confidence. But what I would expect someone means like working in any clinic, just taking a radiograph, being able to identify that the stomach is too big, the small bowel is too small, the cat is vomiting. Then, I mean, to put those dots together, I would have the expectation. Then going as far as saying, or having the confidence of saying that's a foreign body and it's in the duodenum, I think that's kind of the next step. It's a bit harder, in particular having the confidence, because now here is easier, but if you're on your own in the clinic, you have that stress, you need to make a call. This is not that different from, I don't know, this, or I don't know, having that confidence is harder. I think, you need more experience, but being able to identify and feel confident that that's a very distended stomach for being a cat. And then that the small bowel is there's no question that is normal in terms of diameter. Those are the two big calls in this case.
Yeah. I think the hard thing when you look at it is it looks, I think this is colon down here. And
yeah. So let's draw that, because in the beginning there was some drawings with which I almost agree 100%, but not 100%. So if we go colon, I will go here, and I think it comes here.
Yeah.
Okay.
Yep.
And if we come here, I think we are going here, and it comes here. And then if we come here, I think we are going this way.
yeah.
And so this exercise of having someone pointing at things, I think it is basically a brain training. Then after a while, you don't need the effort. Your brain tells you right or wrong. Sometimes you are, again, overconfident and you get it wrong. But being able to identify borders and stuff, more in the abdomen where there's not that much contrast, is a training. It's just training. You get to start seeing more. Remember that we see with our brain a lot. So it's our brain being able to put things together and count borders together and all of that. That's a training situation. That's why the residency, like doing a residency, is so cool. It's cool because we have feedback. So that's very good. So you go one way and then you have someone telling you, no, I think this. But also, not only so much for that, but because you're exposed to I don't know, 20 cases a day. So if you multiply that by 3 years, your brain has been in front of these images for so many hours that even if you don't want, makes sense, you are just training that. And you probably are not going to do a residency, but look at the images, look at them, and then that, I think that trains your brain. Is how many images. So if even if the case is not yours, challenge yourself. Do you see something at the moment? So the more is being in contact, being challenging your ability to see things.
I think always the problem is in practice, you're always doing this in a hurry, I find. And because you're doing it in a hurry, you tend to jump to conclusions rather than look at detail. And you need to just sit down quietly sometimes and look at the detail, which is what you're teaching us to do. And that's brilliant. But we need to make ourselves do it.
I completely agree with you. And they ask me when I'm walking by, and if you talk to people in the clinic, they will know, they will tell you my answer is, hold on a minute, give me the name. I'm gonna go to the room to take a look.
Yeah.
I'm not gonna look at them here in the corridor.
No.
I know that I'm gonna make a mistake. So I'm gonna go to my room. It's dark. Don't bother me. Give me 2 minutes to sit down and identify, go think aloud, hypothesis test, then come back, conclude, think about how confident I am about the findings. There's no way you're gonna be able to make a good diagnosis if you don't find those conditions for yourself.
No. No, that's right.
Yeah. That's very
I think
clear.
it helps a lot as well if you have good nurses who are trained to actually take the images so that then you can spend your time looking at them rather than waste time getting the images, and also saves you from, when you're taking them, sometimes you get distracted. If you see something on the first one you take, you just hone in on that, and then you might not get all, both laterals in the abdomen, and then you can miss stuff. So I think that helps us as well, just having really good nurses that do that.
Yeah. No, I agree.
You have your routine in the clinic. So many problems. That one is one. Positioning, being in a hurry with the positioning, dealing with the acquisition. Which kind of monitor do you have in that room? Most of the monitors that they are there is just to check that actually the image is there and to check the positioning. Don't read the image there. It's just one image. You cannot put 2 images together. Most of the images now with the online viewer, it's just in the workstation that you sit down and write reports. That's just one monitor. I'm sure there is a lot of light. I'm sure there is a lot of distraction. So having a place in the clinic where you have like a relatively nice, doesn't need to be like super expensive, but 2 monitors where you can put one image next to the other in a relatively quiet, you take 5 minutes. I think if you take that as a routine, you're gonna save time. It's not that you're wasting the time. You're gonna be saving time because you're gonna be able to make a good call. So it's just being aware of what are the conditions, what are the things that make. If we spend 1 hour, I know that we go in detail, but I remember training residents, you go through every case, and there are some cases where we are all in agreement, boom, done, round it, go next one. But I remember situations where we discussed cases half an hour because it wasn't clear and there was a teaching situation. And well, this is what we do. We need to take that time, we need to discuss, and that's it. Yeah, so I like your comment, and I completely agree. For me, and I would say probably for every radiologist, because we know how important that is, then we don't negotiate it. We don't negotiate that. We want our time. We want to be able to think about images, take a look. But yeah, I agree. In the clinic is a lot tougher. But yeah, it's perfect advice.
What you say about focusing on one thing and becoming blinkered is what's called heuristic. And it's very easy to do in medicine too, in diagnostics. I notice practitioners are quite prone to it sometimes. And another group that are is the police. They'll decide who's guilty and then try to make the evidence fit it. So yeah, it's a big trap. And I suppose that's one of the things that leads me to always point out the peripheral things that are not clinically relevant. But every time I make a mistake, everybody learns a lot more than if any, if you make a normal comment, a correct comment, I think.
Yeah,
I agree. And that's
absolutely.
why I think the culture, and I think it's a cultural thing. And I think working in the culture that is scared about thinking aloud is a very dangerous culture. I prefer the culture where we think aloud and we say, I don't know about that. I don't know about the other. In 90% of the cases, we may conclude that is something not to pay attention to. It's something to decide not to go further. But at least we mention it. At least we talked about it. At least we consider it, and we never hide it. We just put it out, and then we feel okay about putting all of that, all of those questions out. I completely agree. And on a personal note, it makes me happy. It makes me work in a place where I feel that I can, with colleagues, where I feel I can think aloud and put things and then explain why I may not know some things, or why I make a comment that then I need to take back, but I don't feel like I'm stupid. I thought about something and then I realized, oh, that wasn't a good idea. That is exactly what the culture where I like to live. Absolutely, yeah. And we all bring different things to the game. Like some people look more in the periphery, some people that are blinded to the center. Some people walk by and say, have you thought about that? And they say, oh, that was a good idea. So yeah, completely agree. Okay, enough for today.
Thanks, Mariano. Have a happy Christmas.
Yeah.